Selective laser trabeculoplasty in the era of OTC blood thinners, Hyphema and IOP spikes. Selective laser trabeculoplasty, SLT, and Argon Laser Trabeculoplasty are laser treatments used to lower eye pressure in glaucoma. SLT uses a short, low-energy laser pulse to target just the pigmented cells of the eye's drainage mesh, the trabecular meshwork, whereas AL older technology uses a higher energy laser that can cause more tissue damage. Both are generally safe and outpatient procedures. However, in recent years, many patients take over-the-counter OTC blood thinning supplements or medications like low-dose aspirin, fish oil, vitamin E, ginkgo biloba, etc. for heart health or general wellness. Patients often ask whether these supplements could increase bleeding or pressure complications after SLT-ALT. This article reviews the evidence. We explain hyphema, bleeding inside the front of the eye, and transient intraocular pressure, IOP spikes, and how, if at all, anticoagulant supplements might affect their incidence or severity. We also discuss risk factors, what to tell patients before the laser, and how doctors monitor and treat these complications after the procedure. How laser trabeculoplasty works. SLT and ALT aim to improve fluid drainage from the eye to lower the pressure. In ALT, the argon laser causes visible burns and scarring on the trabecular meshwork, which can work to open nearby drainage channels, but also often causes inflammation and short-term pressure rises. SLT, developed later, uses very short pulses that selectively heat only the pigmented cells in the meshwork. This triggers a biological response, release of cytokines like interleukins and a change in local cells that helps clear debris and improve outflow without permanent scarring. Because SLT is gentler, about 1% of the energy of ALT, it typically has fewer side effects like prolonged inflammation. Both methods are still used, though SLT is more popular today due to its safety and repeatability. After the laser, patients still take medications as needed, but SLT often lets some people reduce their eye drops. Bleeding in the eye, hyphema. After laser trabeculoplasty, a hyphema is blood in the anterior chamber of the eye, the fluid-filled space between the cornea and iris. It can occur if blood vessels in the angle or iris are damaged. After laser trabeculoplasty, significant hyphema is very rare. In fact, the published literature documents only 2 confirmed cases of hyphema after SLT. In one case, a 77-year-old patient who was using non-steroidal anti-inflammatory drugs, NSAIDs, oral painkillers, and anti-inflammatory eye drops, developed a hyphema 3 days after SLT. In the other reported case, a small bleed occurred during the SLT procedure, but it cleared on its own. Importantly, no cases of hyphema after ALT have been reported. These isolated reports suggest that in most people, SLT or ALT will not cause any bleeding that is visible or harmful. If a tiny microbleed occurs in the meshwork, it usually does not leak into the chamber. The lack of data on supplementation means we can only speculate. It is mechanistically plausible that blood-thinning agents could make even a tiny vessel leak longer. During laser trabeculoplasty, energy can occasionally injure minute blood vessels in the trabecular meshwork or Schlemm's canal, the fluid drainage channel. If a patient is taking strong antiplatelet or anticoagulant medications, even a small injury might bleed more than usual. That blood or clot could theoretically block the meshwork and raise IOP, a phenomenon seen as ghost cell glaucoma in other settings. However, since documented hyphemas are so uncommon, any such effect of supplements is likely minimal in practice. For comparison, studies of routine eye surgeries provide some guidance. One large glaucoma surgery study found that patients on low-dose aspirin did have more mild blood spotting, hyphema, afterwards, but it did not affect long-term pressure control. In fact, the authors concluded aspirin is safe to continue during glaucoma surgery, whereas warfarin, a strong anticoagulant, caused more serious bleeding. In cataract surgery and retinal procedures, experts generally recommend continuing low-dose aspirin or similar agents because the risk of clotting is often greater than the small risk of bleeding. Analogously, most eye doctors do not routinely stop blood thinner supplements or aspirin before SLT. In eye surgery guidelines, SLT is listed among procedures where continuing blood thinners is acceptable. The key point is that for routine SLT-ALT in an open-angle glaucoma patient, brief use of low-dose aspirin or fish oil is usually not considered a contraindication. But every case is individualized. If a patient is on potent anticoagulants, like warfarin, DOACs, or dual antiplatelet therapy, the doctor will weigh serious bleeding risk versus clot risk more carefully. Transient IOP spikes after laser trabeculoplasty. It is well known that temporary pressure rises can occur after laser trabeculoplasty. Most of these IOP spikes happen within the first 1 to 24 hours. In clinical studies, such spikes are uncommon. For example, a key FDA trial of SLT reported a spike, an elevation of several micrograms in about 6% of eyes. A 2016 review found similar numbers. Roughly 4 to 5% of eyes had a short-term pressure rise after SLT, compared to about 3 to 4% after ALT. These spikes are usually transient, often catching up within a few hours or days, and do not persist. Risk factors for a post-laser IOP rise include heavy pigmentation or debris in the drainage angle, previous trauma, or pre-existing angle conditions. For example, patients with pigment dispersion syndrome, lots of pigment flakes in the angle, have shown much larger spikes. One case series reported pressures jumping into the 30 to 46 mmHg range after SLT in pigmented glaucoma patients. On the other hand, routine cases of primary open-angle glaucoma normally see only minimal rises. The exact cause of these spikes after laser is not fully understood, but it is thought to be from debris or pigment blocking outflow temporarily and/or a short-term inflammatory response. Could blood thinners make a pressure spike worse? Again, there is little direct evidence. Most pressure spikes after SLT seem unrelated to bleeding. They occur even in patients not on blood thinners, likely due to release of debris or a mild inflammatory reaction. If a microhyphema did occur, any blood cells or clot in the drain could certainly worsen the blockage temporarily. However, since actual bleeding is so rare, routine supplements are not expected to dramatically change the risk of an IOP spike. Notably, giving pressure-lowering eye drops or oral medication around the time of laser has been shown to reduce these spikes. For instance, prophylactic drops like brimonidine or apriclonidine given before or after SLT lowered the risk of a 10 mmHg spike by about 80 to 95% in trials. This practice is more important than worrying about supplements. Blood-thinning supplements. Which ones and what they do? Blood-thinning supplements come in many forms. Common examples include omega-3 fish oil, vitamin E, ginkgo biloba, garlic extract, and others like turmeric, curcumin, or ginger. These substances are thought to reduce platelet stickiness or slightly prolong clotting time. In most cases, their effect is mild. For instance, research shows that standard ginkgo extract has essentially no measurable effect on platelets or clotting time in clinical trials. Likewise, high-quality studies of fish oil have found that continuing fish oil around surgery does not increase actual bleeding or transfusion rates. In other words, while fish oil can biochemically alter platelets, real-world surgical bleeding was not higher in patients on fish oil. In contrast, medications like prescription aspirin, clopidogrel, or warfarin are stronger anticoagulants. If a patient is taking those, special care is needed. NSAIDs, like ibuprofen, also mildly inhibit platelet function. Cleverly, in one Hyphema case after SLT, the patient's use of NSAIDs was noted as a possible cause. If a patient uses any potent blood thinner, even herbal ones in high doses, the doctor may advise stopping it a few days before SLT as a precaution, just to be safe. But for most OTC supplements at normal doses, the evidence suggests they do not significantly raise bleeding risk in eye procedures. In pre-procedure counseling, doctors should ask patients about all supplements and medications. If the patient is on aspirin or prescription blood thinners, a discussion with their primary doctor or cardiologist is warranted. Often the answer is that for a relatively low-risk laser like SLT, especially if done over 360 degrees in one eye, these medicines can be continued. For warfarin or DOACs, the risk of stopping them, e.g. stroke, may outweigh a tiny extra eye bleed risk. The doctor will tailor advice. For example, some surgeons advise stopping high-dose vitamin E or herbal blood thinners 1 week prior to any eye surgery, but this is mainly cautionary. Assessing risk and pre-laser planning. Before SLT-ALT, the eye doctor will evaluate risk factors in each eye. Eyes with abnormal blood vessels or inflammation are higher risk. For instance, active iris or angle neovascularization, as can occur in diabetic or retinal vein occlusion glaucoma, is a contraindication. Such eyes bleed easily, and SLT would likely induce a large hyphema. In those cases, other treatments, like injections or surgery, are chosen instead. Likewise, eyes with very narrow angles or angle recession from trauma might behave differently. In routine open-angle glaucomas, if a patient is on anticoagulants or antiplatelets, the doctor will note this. Low-dose aspirin is usually continued, but double antiplatelet therapy, aspirin, clopidogrel, or warfarin may prompt additional discussion. Another factor is the degree of angle pigmentation. If the angle is heavily pigmented, seen on exam as dark pigmentation or pseudo-exfoliation material, some surgeons may treat only 180 degrees of the angle initially, then follow the eye more closely, rather than doing a full 360 degrees laser at once. This can limit any acute reaction. However, most physicians do all 360 degrees in one session and watch carefully afterward. In all cases, patients should be counseled before the laser that a small amount of blood in the eye or a temporary pressure rise is possible, and usually not serious. They should be instructed about warning signs like sudden vision loss or pain, which would warrant immediate care. In summary, risk stratification means identifying 1. Patients on strong anticoagulants or with bleeding disorders. 2. Eyes with abnormal vessels or inflammation. And 3. Technical factors, angle pigment, previous surgeries. Counsel patients accordingly. For example, because you take aspirin, we can still do SLT, but we will monitor carefully. Your bleeding risk is still very low. The key is informed discussion about very small risks. After the laser, monitoring and management. Immediate post-laser, after SLT or ALT, the doctor typically applies anti-inflammatory eye drops, steroids or NSAIDs, and may give a fast-acting pressure-lowering drop, like apraclonidine or brimonidine, before or right after the laser. This helps prevent an acute IOP rise. The patient is usually kept in the office for a short time. Many surgeons measure the eye pressure about 1 hour after the procedure to check for any immediate spike. In practice, only a few % of patients have a significant rise. If the pressure is moderately elevated, for example, 6 to 10 mmHg above baseline, at 1 hour, a doctor may add more drops or even give a short pill like acetazolamide to bring it down. If the pressure is dangerously high, often defined as above about 30 to 35 mmHg, or if the patient has symptoms, stronger treatment is given immediately. Next day and short-term follow-up. Patients are typically seen the next day or within a few days to recheck the eye. The doctor will look in the front of the eye with a slit lamp to see any bleeding or inflammation and will remeasure IOP. A very small number of eyes may show a transient layering of red blood cells, a microhyphema, at this point. For most patients, this requires no special treatment other than continuing steroid drops to reduce inflammation. The eye pressure is monitored. If it is a few points high, more medication can be added. By 1 week post-op, any minor redness or cells usually clear, and the final pressure-lowering effect of the laser is establishing itself. Managing hyphema. If a noticeable amount of blood were present, standard hyphema care applies. This includes having the patient rest with the head elevated, using an eye shield to avoid rubbing, applying more frequent steroid drops to limit inflammation, and possibly eye patches. Aspirin or NSAIDs are stopped during any bleeding. If the IOP is elevated due to the blood because red blood cells are clogging the drain, glaucoma eye drops or oral medication are used to control the pressure. In extreme cases after trauma, doctors use clot-busting drugs, but this is almost never needed after SLT. A large or non-clearing hyphema is exceedingly unlikely with SLT, but if it happened, the clinician would manage it much like any postoperative bleed. In reported SLT cases, the small hyphema resolved on its own with no vision loss. Managing IOP spikes. For pressure spikes, most ophthalmologists have a threshold for intervention. A modest rise, for example 5 to 10 mmHg above the patient's usual level, may just be watched or treated with an extra drop. A higher spike, over 15 to 20 mmHg above baseline or an absolute pressure into the 30s, is taken more seriously. In those cases, immediate steps might include, in addition to drops, oral carbonic anhydrase inhibitors like acetazolamide, or even admission for pressure-lowering medications. The goal is to protect the optic nerve from any damage. After the first day, any burst of pressure is likely to subside with treatment. At longer-term follow-up, weeks to months, the doctor assesses the overall success of the laser in lowering IOP and adjusts eye medications accordingly. Protocol summary. In essence, the post-laser protocol is check IOP 1 to 2 hours after the laser, recheck the next day, and follow up in about a week and 1 month. During these visits, any sight-threatening issue, such as uncontrolled pressure or a large hemorrhage, would be treated promptly. If a hyphema or spike occurs, the patient is kept under close observation until it resolves. For example, one consensus guideline notes that SLT is usually done without stopping blood thinners, but does advise gentle pressure patching after if needed to prevent oozing. Doctors also warn patients, if you notice new severe pain or vision loss, come in without delay. Conclusion. In summary, laser trabeculoplasty is a very safe glaucoma treatment with only rare complications. The available data show extremely few cases of hyphema after SLT and no reports after ALT. Transient IOP spikes happen in only a small percentage of patients, on the order of 5 to 6%, especially if the angle is heavily pigmented. The mechanistic concerns that blood-thinning supplements might increase these risks seem largely unproven. For example, a systematic review found no excess surgical bleeding in patients taking fish oil, and trials of ginkgo leaf extract showed no change in clotting parameters. This suggests that common OTC supplements and even low-dose aspirin probably do not significantly raise SLT-ALT complication rates. Nevertheless, doctors will remain cautious. Before the procedure, the eye doctor will review all medications and supplements. Patients should disclose if they are on aspirin, clopidogrel, warfarin DOACs, or herbal blood thinners. The doctor may advise pausing very potent agents, but often reassures patients that SLT-ALT is low risk. Proper counseling means explaining that minimal bleeding or a short-lived pressure rise can happen, but is usually harmless and treatable. After the laser, the patient's pressure is checked promptly, often within an hour, and then on follow-up visits, so that any spikes or bleeding are caught early. In cases of significant rise in pressure or a sizable hyphema, standard treatments, pressure-lowering drugs, eye rest, steroids, are applied. For the vast majority of patients, taking OTC blood-thinning supplements will not change the outcome of laser trabeculoplasty. As one review put it, SLT does not cause appreciable bleeding in normal eyes. With careful preoperative assessment and vigilant post-op monitoring, any rare complications can be managed effectively. In the end, the benefit of laser in lowering eye pressure generally far outweighs these minimal risks. Tags: SLT, Selective Laser Trabeculoplasty, Hyphema, IOP spike, blood thinners, glaucoma, fish oil, ginkgo biloba, laser trabeculoplasty, eye surgery monitoring. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.